Hi. I thought I would give you a little bit more of an update from a research point of view. Every now and then I do lit reviews. I try and do a big lit review every 3 months and then get through it over a month or so, which is what I've been doing for a while, just to make sure I haven't missed anything, because we always miss whenever, papers are coming out all the time, and often you'll find something that was 10 years ago but makes you really think. So this was a paper which I've read lots before, but I came across it again recently and I thought, this is lovely. So this is a really good paper for people that are getting into understanding bladder pain syndrome. So people that want to, from physios, if you've got bladder pain syndrome yourself and you want to look at a good an overview of the treatment, but also kind of our approach to it these days. This is a really good paper, and it was before its time. But that's because it was written by Kenneth Peters, who's brilliant, and he's one of our great urology researchers in the field. So it's Peters and Carrico from 2006, so as I said, quite old from a research point of view. But I love this paper because it nicely states all of the things and all the principles that we work to vaguely at the moment. It lays them all out and has some nice statements to make. So I'll put all of the references for this underneath the video. If you're watching it on YouTube, you need to go over to my website to get all the blog underneath and the references. So to begin with, they talk about, Donna and Kenneth, Peters and Carrico, talk about the old science understanding of interstitial cystitis, which I find a lot of the time we're still battling. And this was 12 years ago when they were talking about the old science, but we're still battling this a lot in our medical population. That because the bladder is storing what is technically a toxic substance to the body, urine isn't exactly something that we need, it's our byproducts, the stuff that we don't need anymore, we want to evict. We need to protect ourselves from these irritants, and so if that protective layer of the bladder, so the inner lining of the bladder, becomes compromised, then urine will irritate the lining of the bladder, penetrate the detrusor muscle, which is the muscle of the bladder, causing proliferation of mast cells, which are part of our kind of inflammatory network or immune cells, which will then cause nerve upregulation and cause the symptoms of bladder pain syndrome, so urgency, frequency, bladder pain, pelvic pain. That's old science. However, and they point out, no trials of treatment for the lining of the bladder have shown efficacy, and it's potentially because we haven't found a good enough compound, potentially because the epithelium isn't actually involved in the pathogenesis, so how the condition develops. It's more to do with other stuff. It's possibly a victim, not a cause. Or we've included what we call a heterogeneous population, so a population that is incredibly varied, which we know humans are, and that's our population of bladder pain syndrome patients. We're all humans, we're all very different, we're on a spectrum. And so they conclude there is little solid evidence of causational role of the dysfunctional epithelium of interstitial cystitis, as it was called back then. Yes, great. So they say we need to take the focus away from the bladder, and by oversimplifying our diagnostic understanding of the bladder, of interstitial cystitis, it leads us to initiating therapies towards treating the bladder that are ineffective. I could shout this. There was another paper, Peters 2007, that I quote all the time, that says limiting treatment to the bladder is ineffective in the long run. You need to treat the pelvic floor, which I use to justify NHS services, any of you NHS workers out there, which is quite a good one to get hold of. To be honest, anything written by Kenneth Peters is a good read in this area. So it's imperative that the clinician takes a fuller, a more holistic understanding of the patient when they look at them. So we need to evaluate the pelvic floor. What I really like about this paper, if you can get your hands on it, are some of the images. So we've got a really nice image of the pelvic floor here, and we've got a lovely image of palpation of the pelvic floor muscles. I mean, they look a bit like a spider's web. They don't look particularly like they are in real life, but it kind of gives you an impression of actually what the pelvic floor physio would be doing by palpating, by touching those pelvic floor muscles. And they talk about lots of different stuff in here. So they talk about how why this pelvic floor starts to get painful, that potentially a noxious stimulus, which doesn't mean an actual attack, but something noxious, which means threat, or means bears, as I keep talking about, may trigger the release of nerve growth factor, and substance P, which then in the periphery, which causes the mast cells in the bladder to release pro-inflammatory compounds, which then causes neurogenic inflammation of the bladder lining. That will cause bladder pain, vulval pain, vaginal pain. If you're a woman, if you're a man, it will cause testicular pain, potentially penile pain, potentially gooch pain, pelvic pain. And you get a reflex hypertonic state of the pelvic floor. It goes up into spasm, walking around like this inside. It's a really nice kind of summary of how that happens, and it's very quickly done. It's very nicely summarised. And there was something else I was going to say about that, but I've forgotten. I'll come back to it. And he talks about neural crosstalk, so how you, because of an effect in one area, you can get crossover into an effect in other areas. And we know this in our irritable bowel syndrome, that we get a lot of interplay between the different organs, that actually negative effects on one organ because we've got a perceived threat or an actual threat or a pro-inflammatory process occurring, we can then get neural crosstalk, the nerve fibres not really understanding where everything's going, working in the same way, trying to create this complex threat response to protect you, means that then your bowels start to get bad. You might get achy bowels, you might get inflammatory bowels, you might get IBS symptoms. And they talk about some of the reasons why this can occur, some of the potential threats. In fact, I think it was at the time they were talking, they stated there haven't been any trials, but actually there have been studies now looking at this. But I think what they were doing as urologists is trying to open other urologists' eyes to the fact that a noxious stimulus doesn't have to mean an infection or a trauma, but it can also be something psychological, which we now fully understand. And we really respect. It's well understood within the literature. So they talk about the risk of abuse, and they talk about abuse not just being physical abuse. I mean, the stats are really horrible, which I won't go into for that reason, but they also talk about things like domestic violence, and not necessarily physical abuse, but emotional abuse in quite a lot of it, or heightened stress states within families, also being noxious stimuli, to potentially causing issues. And it's certainly something that I find a lot, which is why with all of my complex patients or complex history patients, so everyone's complex, but patients that have got have been seeking out treatments and help for a long period of time, and not necessarily getting those answers, or getting some answers and pieces of the jigsaw, but they're not all put together. You have to take a massive step back and look at the whole of their life, because there's no way that you'll go in there, as Peters in 2007 said, and just treat the bladder to make bladder pain syndrome better. You've got to make sure the whole of their life is sorted. You're not necessarily as a physio responsible for that, but we certainly have to acknowledge it. So that's why I do my Find Your Bears pictures with my patients, and I've got some lovely examples that I'm going to try and convince some of my patients to let them share. Obviously they're anonymised, so you can see the kind of things that we come up with. But that takes into account all the potential threats, all the noxious stimuli in their life. So they talk about a good examination involving looking at the full past medical history, a cotton swab for vulvodynia, which is vulvodynia, very palpation test, looking for reflexive responses of pain on cut and bud testing, vaginitis, pH testing the vagina, making sure they haven't got an infection, pH should be 4.5, any hormone treatment that you require for vaginal atrophy. So again, we're looking again at the female population heavily, just because we know that female population of people with BPS is higher. And they also, interestingly, talk about cervical motion test and whether moving the cervix hurts, which made me think about visceral mobilisations, because again, an area we don't have any much research, and the research we do have is a bit wishy-washy, but we have a lot of experiential evidence that actually doing some visceral mobilisations of the bladder, making sure that the organs slide and glide happily around, and we've not got, I don't like talking about adhesions because it gives you something to fixate upon, and adhesions don't necessarily cause pain, but certainly lack of mobility might cause pulling, tension, that kind of feeling, which could be interpreted as bladder filling or bladder pain. So that was interesting, the fact that urologist is talking our language. And they talk about a pelvic floor muscle pressure test. Woo, nearly lost the papers. Which is how we palpate for pelvic floor. They do it quite sequentially, but I don't think they do it like that now, and certainly not in clinic. Everyone does it differently. You need to check everywhere. But palpating the pelvic floor, they talk about often when you palpate the pelvic floor, it will recreate symptoms, which is, we all know this within physio, which is why we do it so much. And quite often I'll find anterior puborectalis, obturator internus, both sides will recreate bladder pain and iliac fossa pain, respectively. And they briefly summarise, they say there's been no evidence, but if you've watched any of my other videos, you'd have seen recently there have been a lot more papers over the last 10 years looking at pelvic floor myofascial release. So looking at that process of calming the muscles down and working with them. And they create the Vice paper, which looked at 1 to 2 times a week for 8 to 12 weeks just to calm everything down. But certainly it should continue until the symptoms and tenderness has ceased. And in many cases, it doesn't require intervention from a surgeon or intervention to give them drugs for the bladder lining, which we know. And actually, the evidence doesn't say 8 to 12, it says around about 5 to 6 weeks. When you summate everything, that's how much we need to be doing. It's just until we get that overflow of symptoms so that when we palpate the pelvic floor, it's not causing loads of pain. Right, so that was that paper, which is what I really love, which basically looks at levator spasm as a significant cause and contributor of bladder pain. I love it so much that I've gone and drawn a little square around this bit and gone, yes, I agree. Okay, so that was from 2006, right up to date-ish to 2015. The Ackerman paper, which backs this up nicely, which looks in a much more scientific way at the tonicity, so how tense a pelvic floor muscle is in female patients with IC BPS, bladder pain syndrome, please, let's keep calling it that. And they found, I'm just going to read it to you because it's great, patients with BPS have pelvic floor hypertonicity on MRI, so we know that they've got a tighter pelvic floor, which manifests as a shortened levator, which is just another way of talking about the muscle, increased posterior puborectalis angles, which is how tight your pelvic floor is causing that bowel angle at the back, which makes it a bit more difficult to go for a poo. Getting that stool to come around the corner, which is why you need to put your knees up on a squatty potty to reduce that angle, so we've got a little bit better. Not necessarily, obviously other stools are available, but I love a squatty potty. And decreased puborectal distances, so getting tighter because everything's held. We identified evidence of pelvic floor hypertonicity in patients with BPS, which may contribute to or amplify pelvic pain. And as usual, they've said further studies required. It's a statement that should be banned and just assumed. More interestingly, for you physios out there, the current model of BPS pathophysiology suggests that central nervous system dysfunction results in aberrant responses to stimulation of pelvic visceral and somatic neurons, manifesting as chronic pelvic pain out of proportion to demonstrable pathology. So, stimulating the nervous system of our viscera and our somatic nerves, so our visceral nerves, somatic nerves, creates or is manifested as pelvic pain. We're poorly understood by the brain or manifested in that way because of a constant threat response. As a result of limbic efferent stimulation, remember you AF and you F off from the brain. Simon Mockett, 2003, 2004, taught us that. I can't remember. Nikki will be able to tell me which year it was. So you F off from the brain. So limbic efferent stimulation, pelvic musculature undergoes tonic contraction. So our limbic system again, we're coming back to our limbic system, which is our emotional centre. And if you don't know what I'm talking about, go have a look at a couple of the videos, read the thing about my complete guide to bladder pain syndrome. It talks a lot about limbic system. So because of the limbic involvement, we get that tonic contraction of the pelvic floor, and pain afferents from the pelvic floor and the bladder transmit this noxious stimulus It's just a stimulus, but it's perceived noxiously, back to a sensitised limbic system, reinforcing efferent contraction of the pelvic floor muscles and perpetuating the cycle of chronic pelvic pain. I like this paper. So we get this continuous noxious stimulus understanding, which then perpetuates that the pelvic floor gets tight and stays tight. And again, it talks about given crosstalk between the pelvic floor, the bladder and the bowel neurons at the spinal cord. Pelvic floor dysfunction may perpetuate voiding dysfunction, so having difficulty having a wee, defecatory dysfunction, difficulty having a poo because we've got that angle, it's difficult to relax, urinary urgency and frequency, and pelvic pain. We know urgency and frequency of the pelvic floor. A lot of the time, the symptoms of that are created by tension in the pelvic floor. It's really easy to sort. So the increased tension in pelvic floor musculature seen on MRI may be the radiographic correlate of an altered activation of cortex, visceromotor areas, and increased connectivity between the central nervous system controlling the pelvic floor and bladder function seen in BPS patients. And more scans needed. Delete that sentence. Very exciting. We know that we need to be treating the pelvic floor. Peters was kind of ahead of his time, or at the forefront at the time, 10, 12 years ago, talking about the fact that the pelvic floor needs to be treated in bladder pain syndrome. And then just me going through the research, picking out stuff every now and then that I think I've missed. A paper from 2015, the MRI studies, backing up again a little bit more in detail about why the brain controls that pelvic floor tension and how that can lead to some of these symptoms of urgency, frequency and pain in the bladder, and how treating that gives a potential window of opportunity to relieve these symptoms. And in my experience, I would say that it does significantly. So thanks for listening. If you're interested, I post lots of researchy stuff every now and then about stuff I find interesting. So I hope you did too, and we'll speak soon.